Now, our next moderator, Dr. Venkatesh, he has done his MBBS from the VM Medical College, Solapur, and PG, MD from the GS Medical College, Mumbai. He has done his fellowship in pediatric intensive care from BJ Wadia, Mumbai. Now he is working as professor and pediatric intensivity in Apple Saraswati Hospital, Kolhapur. He's working as a PG teacher in medical college in Apple Saraswati Hospital for DCH, DNB, and MD Pediatric. He's at very younger age. He's working as a PG teacher. He's young, dashing, and dynamic in Kolhapur. He's very well-known intensivist in Kolhapur. Hand over to you, Dr. Venkatesh.
Yeah. Good morning, everybody. Can you hear me?
Yes.
Yeah. Yeah. First of all, I'm very thankful to Mirgunde sir and Dr. Prasanna for giving me opportunity to moderate this session. I am very happy to introduce our today's speaker for the next talk, Dr. Sumant Patil. Dr. Sumant Patil, he has done his MBBS from Pravara Medical College, Luni. After that, he has done his MD Pediatrics from JNMC, Belgaum. After that, he was in the UK for 10 years. He has done his DCH, MRCPCH in UK from 2004 to 2014. In this, his tenure over there, he has done a fellowship in pediatric intensive care and neonatology in Nottingham. Currently, he is working as a head of pediatric intensive care at Dinanath Mangeshkar Hospital from 2014 till date. He has multiple national and international publications in the field of pediatric intensive care and neonatology. He is active in Indian Academy of Pediatrics in the form of IAP EPIC course, as well as he is a teacher for IAP fellowship program in pediatric intensive care at Dinanath Mangeshkar Hospital. With this introduction, I request Dr. Sumant Patil, sir, to start with his session. Thank you.
Thank you, Venkatesh. Can you hear you? Can you hear me?
Yeah, yes, sir.
Yes.
Very well.
Yes. I'll just share my screen with you. Yeah. Good morning, everyone. Thank you, Venkatesh, for the introduction. And thank you, Prasanna and the Kolhapur Academy of Pediatrics for inviting me for this interesting talk. We really had two beautiful lectures before me, talking about how to take care and what is the general perspective from Dr. Joshi and Dr. Pandya. Now, I think it's time for us to get on to the battlefield. Interesting enough, my first slide has a picture from Lombardy. Actually, this is not just a picture. It's actually Lombardy. It's a Lake Ova from Lombardy, and that's where actually we saw the worst part of this COVID pandemic, which caused lots of deaths, which has caused lots of morbidity and the stress all over the world once this pandemic began. And I want to just remember these things, that we are still not out of it. Let's go to the first slide. Look at this. This today morning's data. Today morning, also I would say yesterday afternoon late, and it says there are so many numbers, and look at that number in between there. India is now crossing 1 lakh deaths, and we are nearly 10% of the deaths, total deaths in the world. World is around 10,25,729 deaths, and we are at 1,842 deaths. So we are not behind. World is going, and we are actually catching up. Now this is our catching up. We are really galloping fast. We are hardly probably a lakh behind United States, and we'll be the world toppers, which is not a great thing for us to have. And look at the number of deaths as well. We are around 1 lakh deaths here, which tells us that this pandemic has taken a really bad toll on everybody. And why, luckily, there isn't much seen in pediatrics. But yes, that's not actually the truth. We are seeing things in pediatrics, but there is not a very comprehensive data that is available from across the world. So I could collect one or two probably good data here. This was from a European cohort, which was for multi-center, and which talks about the number of patients which were positive with COVID-19 under 1 month, 1 to 1 year, and subsequently. So if you look at these first two lots, these are, so probably under 1 year, there are more and more kids. And then probably after 10 years, there are more kids. So I would think that we should think that under 1 and beyond 10 are the maximum number of kids that we get with COVID positive. United States talks about around 7.3% all COVID infections in children. That was the data from CDC. The last collected was in August 2020. And there is still a lot of comprehensive things there to come. Look at the data that you have from CDC. Particularly the first one, the cases by age group. If you look at this, the number of cases up to 5 and 17 years. So we do not have a lot of them. So 1.8% 0 to 4 years, and 5 to 17 years, we have 6.8%. So not that much. And the rest of the age groups, the middle age group has got highest number. Now look at the deaths by age group. We don't have anything really here. From 0 to 17 years, hardly 0.1% and 0.1% in both age groups. That does tell us that the severity of the pediatric COVID is not that bad here, but still we cannot neglect that. And they have come up with some data from the recent sharing that they have is cumulative rate of 8 per 100,000 population is COVID infection in kids, and highest among children under 2 years of age, as obvious as we said, is now sort of 24.8% per 100,000. And the hospitalization rate ranged from 2.5 to 4.1%. And who were hospitalized with COVID-19, approximately 33% required intensive care and 6% required invasive mechanical ventilation. Really, this is not that we cannot say that we don't have severe COVID in pediatrics. They do have severe COVID in pediatric patients, and we need to be really aware of this. Although this data which I was talking about is a European data again this is Washington data. Again, here also a similar sort of age group distribution that you could see. Up to 15 to 20 years of age group, there would be a lot of numbers here on this side. And if you look at this chart, age group chart, less than 1 year is probably around 30% of them required hospitalization. And critically ill were around 10% under 1 year of age group. The middle age group wasn't very significant. More than 15 years age group again had critically ill patients really high on that side. So you can see nearly 70% were critically high beyond 15 years. And that has got a lot of implication on the how you look at pediatric COVID. And this is quite surprising, because we haven't seen so many patients as such, which was so bad for us. But the US data does show that. And although they also come up with this thing that the youngest, of course, as we said, youngest and the oldest children were more likely to be hospitalized. The oldest were most likely to be requiring critical care, nearly 70% of them. And underlying conditions were present in around 39% of patients. And it is mentioned there about critically ill patients more likely to have underlying condition, but there is also a situation where the 55% of patients, which out of them 37 hospitalized and 22 critically ill, did not have anything in their underlying condition, which is very important. And that also tells us that we must take care of, very, very strict hygienic measures, social distancing, hand washing, as much as we could, even in pediatric age groups. This is Lancet publication in September, quite latest now. And this is a European data again, this big cohort here. Now, if you look at this, under 2, 2 to 5, 5 to 10, more than 10, and age less than 1 month is 40 patients here. The 40% of them were under 2 if you collect them. This maximum number is around here. and a maximum number were not admitted were 40%, but 48% required admissions here. Similarly, more than 10 again has the similar sort of reference. So you can say, looking at this age group, this is data which has talked about how these ICU admissions are in the different age groups. So if you see the baseline here, up to 2 years of age group, you can see highest number of admissions as well as highest number of patients. So these are the patients which did not require ICU admission. These are the ones which required ICU. It kind of tapers off and starts bulging up again. And as it starts going up, it has a big surge here in between this age group. Beyond 10 years, 10 to 17, there is big surge in patients who require ICU care as well as the general population. And the signs and symptoms, those patients with lower respiratory tract, around 25%, even in the patients who were admitted, which were not admitted. And there's a significant difference between these two. So this cohort was around 582 patients, as I said. 25% had pre-existing medical conditions, 62% were admitted to hospital, 8% required ICU admission, and 4% mechanical ventilation. And 3% were on inotropic support, 1 required ECMO support. So it is significant, and we cannot neglect that. So significant risk factors for requiring ICU admission. So younger than 1 month, I would probably make it younger than 1 year. Male sex and pre-existing medical condition, and probably the presence of lower respiratory tract infection at the time of presentation. So these are a few things that you need to keep in mind from the data from 2 strongest corona-affected regions in the world. One is US and the another one is Europe. From our side, the ideal scenario is we do not really have collecting data as such. We have tried to compile our data from DMH. This is just up to July actually. The Joshi sir has spoken about the other 2 months as well. So this data we are analyzing at the moment, and we had total 117 pediatric patients which were admitted, 4 patients which needed actually going into the PNIC, which we have made a separate pediatric and neonatal intensive care unit for COVID patients. We did have neonatal death. I think Dr. Shilpa will talk about that. And we had 2 patients who required O2 support. And one of our patients was a 7-month-old girl, which I'm going to talk about, and required really, really long support, respiratory support, and really had a bad lungs, which looked like almost like an adult patient. Luckily, she survived. So this was a girl who was a 7-month-old girl. She was COVID-19 positive on arrival to ER. She had no obvious history of anybody being positive. But her mother tested positive after she tested positive, and the father was negative at that time. She had a fever for 5 days and started becoming breathless. By the time she came to us, her saturations were dropping to 85%, typical as you would see in adult patients. And very soon she started developing respiratory distress, oxygen requirement. She had a significant amount of respiratory acidosis. Chest X-ray showed hazy shadows in both lung fields. By day 3, day 4, her respiratory distress started getting really worse. So much so that the nearly non-rebreathable mask oxygen could not keep her saturations up. So we had to take her on to high flow nasal cannula oxygen. And believe me, we had to go during this whole 2 weeks that she required high flow, we had to go up to 25 liters per minute of high flow. And if I go to maximum of 88%. The labs were, apart from the interleukin 6, which was 42 on the day of admission, which very quickly resolved back to normal within 4 or 5 days, and the LDH, which had gone up to 1942. Other parameters were not classically raised, such as, the ferritin was normal, CRP was negative for 3-4 times, Procal was negative, D-dimer was not very high, around 492. But she has marked thrombocytosis, high total count, and her neutrophil lymphocyte ratio was 0.9, which was throughout normal, and we had done it throughout or whenever we could do her hemograms, and actually more than 3 is associated with really bad mortality and morbidity, and this child never had beyond 0.9. She underwent 2 echos, which were normal twice during the duration, because we also had something else in our mind, which we'll talk in our last lecture about PINS or MISC. But obviously both the echoes were normal. She had 4 blood cultures which were negative. She didn't have any cultures growth, but her nasopharyngeal aspirate showed a growth of Acinetobacter. So apart from these few indicators here, thrombocytosis, high LDH, high IL-6 on admission, and nasopharyngeal aspirate, which was Acinetobacter, we didn't have anything positive here. And this child had this kind of CT scan. You can imagine this can be compared with any other adult COVID, and as bad as that. Most of the both-sided lungs and posterior aspects were really full of ground glass appearance. And same here, and this is the X-ray on admission. So you can see on admission on X-ray, you probably don't get to see a lot of difference between similar sort of pneumonia that you would normally get in otherwise also. But it is very hard to differentiate. What actually makes this thing really obvious is this CT scan, but we don't do that as a routine unless you have a really child who requires higher respiratory support. But this was the CT scan, and this remained there on the second dot, which was done after 7 days. What were we? What did we treat her with? We started her with high flow support, as I said, quite high pressures, 25 liters per meter. FiO2 was high, and this was nearly 3 weeks ongoing. Slowly started to wean down from day, probably I said day 10 onwards. What was the most important thing? What we did was the aggressive chest physiotherapy, prone positioning, which was not easy for this 7-month-old child because she wasn't understand the instruction and she was constantly irritable with that. So we have to sedate her. We never used nebulizers, but we used inhalers. We gave her antibiotics because she had a persistent fever on and off, and given the use of prolonged use of steroids, we had to give her antibiotics. We initially started her on IV methylprednisolone. We gave an extended trial of 7 days. Also, we started on Aspirin, that is your anticoagulant, within 3 days of admission as her oxygen requirement started to worsen. Then we also changed over to dexamethasone, which actually on a think of desperation because this child was getting really worse. We also used all the other medications that were available and possibly implicated that they might help, but obviously they didn't help us too much. The ivermectin, HCQ, which wasn't really making any difference to us. The hypoxia persisted really bad. What we used was Lasix on 2 weeks onward and use of Thymine, which is usually we use in wet delivery, and that probably had helped us a little bit, which kind of started to drop down our oxygen requirement. Later on, she found to have high galactomannan levels, and we started on voriconazole. The oxygen requirement gradually started to come down from 3rd week onwards, and she went on to nasal cannula for next 3 weeks. She would drop her saturation at just like that. So we had to continue her various modes of weaning. The other thing that she developed was persistent fever 4th week onwards, and despite all the measures that we took. And we also thought that we probably might also looking at this child gradually moving into some other form of infections or probably a late immunologic response. So we gave her IVIG over 2 days, and the enoxaparin was changed to aspirin and given for 6 weeks. So this child was the whole lot actually. It started like an adult, then worsened. The oxygen requirement went ahead, and we could not actually do anything about it. But what we did good was we gave lot of attention to chest physiotherapy, positioning, adequate, frequent positioning with regards to lateralization on both sides. And this child was very difficult to deal with, but nutrition was also maintained effectively. So she could manage, and actually she came out of this. So given this case, what is our understanding of clinical presentations and the severity? So usually high risk cases, the clinical features come with, they come with fever, respiratory and digestive symptoms, and fatigue. These are very top 3 classical symptoms that you get. And laboratory tests, usually you will get leukopenia, lymphopenia, and high CRP. None of these were present in our case, but still it is the highest that you could see everywhere. Abnormal chest X-rays, as it is not very specific, but the chest X-ray would show some changes such as some patchy infiltrations on both sides or unilateral. The severity categorization can be done with these as like you don't have any symptoms, like you can say asymptomatic infections, no features, either clinical or radiological, mild like upper respiratory tract or maybe gastrointestinal symptoms, and moderate like clinical and radiological features of LRTI. Now here comes the crux. This is where the people found as the patients with signs of lower respiratory tract involvement or LRTI probably have higher situations where they can need support for ICU, or they will need support in ICU. The severe patients, they come in dyspnea, they have hypoxemia, they require oxygen, they have refusal of feed, they have an altered sensorium, which again goes into like how any other child will come with hypoxia. And critically, obviously, they will start having more and more organ dysfunction, and eventually they will go into ARDS, shock. Some of them do come into encephalopathy, myocardial dysfunction, coagulation, and these are inflammatory changes, and secondary immunomodulation is required here in these patients. So why and how you deal with these patients? So what one must have is you must have a separate designated PICU if it is possible for all COVID positive pediatric patients. You can put all of them together in one ICU, neonate and or pediatric patients, as we have done here. If you do not have a separate PICU, you can take a section of adult ICU and make it a designated PICU as such. If it is available, you can have a negative ventilation room for your all respiratory patients who are going to require respiratory support, which will generate a lot of droplet dispersion, and that is where the healthcare infections are going to go. So we need to protect our old staff. We must use complete protection using N95 masks and PPEs whenever required, particularly during the procedures. Strict hand washing and pomade care is must. Separate areas for donning and doffing of PPEs, as we have spoke earlier on. And it is not necessary that you keep them in an area where you have no patients of COVID and wait till they become COVID positive. In the current scenario, it is better that when you have any clinical doubts, if there is any distant suspicion about a child presenting like a COVID, you should not wait. You send the swab and take them into the area which could be COVID positive. And of course, if it is really possible, to stay away from the actual positive patients. But if it is not possible, you can't help it. This is at least what you could do. The CDC has given some guidelines about how to use and what other things that you could use. So your routine well childcare, I think we had a good lecture from Dr. Pandya about it. So what are the things that you could use is eye protection, face mask, and routine well, non-infectious acute care. COVID-19 suspicious cases, but negative and unknown status, you should continue to use face mask and eye protection. And if it is possible to use gowns and gloves, if they can be disposable, you can use them to avoid contact with the bodily fluids. And of course, if there are confirmed cases, you use all of them. So 95, then eye protection, gowns and gloves, PPE kits during the procedure. So for all of them, if you see, face masks are for must everywhere. You can see that. And that's very important aspect of that. Another important thing, I think everybody must be aware of this. Everybody must have these put up in their areas of work. If you are looking after COVID patients, how to don and how to doff the PPEs, which actually now has become a routine for everybody. Here in Dinanath, we do not actually use a proper PPE for routine rounds, routine assessments. We use a modified PPE. The actual PPEs are done by the intensivists only during the time of procedures which have highest risk of droplet dispersion, such as intubation, suctionings, and the nurses sometimes looking after COVID patients. So this must be looked after, and this must be put up into your working area. Another way of classifying into mild, moderate, and severe, this is moreover the adult criteria, and we'll come to the adult criteria, we'll come to the pediatric criteria from here onwards. The laboratory tests also, just look at them in general. I'm sure you all are aware what are the significant ones, normal and the significant levels of the labs, particularly the neutrophil lymphocyte ratios, D-dimers, and ferritin. and interleukin-6. The WHO and AIMS, and along with that, even the ICMR has come out with this comprehensive division of patients for pediatric, and IAP has supported them as well. Sorry. So asymptomatic patients, we have mild, moderate, and severe patients, and critical. So the asymptomatic patients, obviously, we all know they don't have any symptoms. They just have no requirements. Mild patients can have fever, cough, and difficulty breathing. They could be tachypneic, and these are the rates. So basically, SARI is what we normally look for. So these infections like infective upper airway or airway infections in WHO criteria, these are the same criteria that they have used here. Moderate cases, increased work of breathing, saturation is less than 94%. And here something starts to come up is PaO2 FiO2 ratio. If you have an ABG, then you can do this. And obviously the oxygen requirement starts worsening here. In the severe cases, the oxygen saturation starts dropping below 92%. There is a lethargy. The PaO2 FiO2 PF ratio starts dropping below 300 into 200. And when they become critical, it really goes down below 200. Very high lactate, metabolic acidosis, and perfusion, hypotension. These patients can be in altered sensorium as well, dehydrated. So this is the stage and classification that we use at the NANAD as well. And this is, the IAP as well has put up the similar one. And another one, which we will talk at the end, will be the PIMS or the MIS. So this is like multisystem inflammatory syndrome in children, which is a new thing that everybody is looking at now. So children who present beyond 5 to 7 days of fever without having a PCR positive, but have features which are similar to Kawasaki's disease, and they come with mainly gastrointestinal disorders, and they may include children who can fulfill actually the criteria for Kawasaki disease, but you must exclude other causes. We'll talk in detail about them. They usually have antibody positive rather than PCR positive. Severity of presentation and the duration of illness and how you can intervene in between. So beginning of the disease, after the incubation period, from first day to 7 days, what you normally see is you normally don't see very much of respiratory symptoms. There will be non-respiratory symptoms predominantly, and there will be strong viremia. So there is a case for antiviral medications. If you can use them in the earlier phase. And similarly, as the days cross beyond 7, then you have more of a thrombophilia, immune dysregulation, and the respiratory symptoms starts worsening. And here comes the role of anti-inflammatory medications. Similarly, the hypercoagulation, hyperinflammation, and lung hypoxemia goes hand in hand, and that's the vasoplasia, which is causing hypoxemia in these kids. So, or this is even the adult situation, which is same as what we also see, but not very often. Then comes the picture and the importance of monitoring D-dimer, starting on Clexane, that is enoxaparin, your CRP ferritin levels, interleukin-6, and that's when some of them go into this phase of macrophage activation and worsen further. So treatment principles, what we have followed is we have divided these patients into mild, moderate, severe, and critical patients. And this is again from WHO and AIMS and as well as IAP. So we divided our patients, as I've shown you before, into mild, moderate, severe, and then we made sure that we do these things for them. Asymptomatic who start tachypneic and have fever get antibodies started, and as a part of pediatric protocol, we also give them Fluvid to counteract with the combined infections. Moderate ones start becoming worse. They start requiring more oxygen requirement. They are again put onto oxygen by nasal prongs and continued with the antibiotics. Here we don't start on any just physiotherapies as such, but we do investigate them in general. Once they start becoming worse, your PF ratio starts dropping. We investigate them more, and they will need higher respiratory support. The documentation of HCQ for these patients has been for pediatric patients, and IIT has approved that. So we put it in our protocol as well. So we use hydroxychloroquine for children with these dosages beyond 6 and below 6. Now, actually, once those who cross this level and are deteriorating are actually the worst ones, the critical forms. We don't see that many. These are the ones which would require all the respiratory support that you would normally require in any child who would go into ARDS. So that protocol has to be formed here. The elective intubation is much better than wetting and exposing your staff onto a lot of droplet dispersion infection. And this has to be done as per the PRDS consensus guidelines. So we must also treat the septic shock here. Use the fluids very cautiously. Don't fluid overload them. Start inotropes early if they are dropping the blood pressures, adrenaline to begin with, and maybe an noradrenaline to add later on. You must monitor them for multi-organ involvement and treat them as and how they require. Respiratory support choices in COVID-19 is really comes to these three and the intubation. But what I would suggest so far, the experience from the adult, that the high flow support is the best way of dealing with these patients, and skipping the CPAP and NIV in general because of the lot of risk of droplet dispersion and in both of them. And actually they don't make any difference. So when you are on HFNC and you're worsening, there's no point in trying CPAP or NIV. Or if you don't have HFNC and then you start on CPAP and the child is worsening, no point in trying NIV. Straight away go down and intubate this child with all the precautions. So basically, you can begin with the flow of 2 to 3 ml per liter per ml per kg, and then FiO2 targeted respiratories used. Everybody must be wearing PPE. This child ideally should be managed in a negative pressure room. You can use modified HFNC, like you use low flow to avoid the dispersion, droplet dispersion, and but use high FiO2 if at all you can do with it. But if not, then you have to go up on the flows as well. The guideline is if there is no change within 2 hours in HFNC, you can consider endotracheal intubation. I would probably make it that if it is worsening within the next 2 hours, then you intubate. And if there is settling down of respiratory tachycardia, and the child appears to start maintaining saturations, then you can manipulate the HFNC pressures and FiO2 accordingly and continue the support as we had continued for nearly 2 to 3 weeks for this child. Similar situation on CPAP is not really a preferred choice, first choice, because of the high droplet dispersion. Similarly, same situation with NIV. So we don't recommend NIV at all. CPAP can be used if you don't have HFNC. But actually, next slide is we're going to talk about the homemade HFNC machines that we can, indigenous HFNC. Now, this is an actual HFNC airworm, Fisher-Paykel, that if you have access to, it is great. We use this one for our patient. Obviously, it has got the nasal prongs and the cannula, which is specifically measures the flow rate, and you can actually measure the flow rate and set the flow rate here as well as the FiO2 accordingly, and you can adjust your FiO2 here as well. Now, if you don't have this, but at least you have a blender. Now see this, your oxygen blender for your CPAP there. So you can use this oxygen blender CPAP. Take out the PEEP generating part of it, connect it to the flow here, and actually start it at 5, 7, 8, 10 liters, whatever you put here, and that's the maximum that you could go here. Flow maximum is 10 liters, and this can be adjusted through a humidifier here, and the connection through to the patients directly. Now you can use the CPAP cannula here. You don't have to use the HFNC cannula, which measures actually the flow rate. That will be one disadvantage here, but at least you could have some sort of a high flow support given, at least up to 10 liters here. Going ahead, invasive ventilation. I hope you don't have to do this. Neither did we, but the guidelines are very clear cut. Do not delay intubation. You electively intubate them. If the child is worsening on a high flow support on CPAP, no point in trying NIV. And it has to be a situation where the person who is the most experienced and can intubate in one go should be taking over, because if you keep on trying, then there is such a high risk of exposure droplet exposure. If possible, video laryngoscope. You do not use the bag and mask here. You use the NRM mask for pre-oxygenation and intubation as well. So because again, that will lead to a lot of droplet dispersion. So at the same time, viral filter must be used if at all you have to. These strategies of ventilation have to be used as per the PRDS guidelines. We'll come to that. Usually you start with lower tidal volumes, volume control ventilation. If you're using good compliant lungs, then you can use slightly higher tidal volume here with a PEEP of low PEEP around 7 to 10. Other way around, if you have poorly compliant lungs, low tidal volume but higher PEEP, and then keep PEEP plant. This is the most important part. Keep PEEP plant at around 20, less than 20 centimeters. So you will protect the lungs at the same time. With the pressure control, can go up to PEEP of 10, maybe 20. This is probably really a desperate situation. Again, the PEEP of 8 to 15, some people have, say 10 to begin with, but obviously you can escalate that. Fluids should be restricted. This is very important. Liberal sedation and analgesia, but sometimes that also can become more of a problem. But as much as possible, keep the child compliant with your ventilation, because this is going to go really bad and for a long time. Advice about neuromuscular blockage is very strong, particularly in adults. Pediatric, it is equivocal, so you can use that velipirim infusion if you really think that there is a significant amount of ventilator syndrome. Prone ventilation, again, very strongly recommended in adults. For pediatric, I would say we do have a lot of risk of endotracheal tube dislodgement, and again re-intubation, again exposure to droplet infection. So, and again, the guidelines and the PRDS has not told about there is a significantly higher advantage over non-prone patients in pediatric population. So it is again ignorable. But if it is possible, you could do it. That's a good way to go around it. And obviously, you have to use HMF filters. This is the heat moisture exchange with viral filters. Is must on the expiry limb of the circuit to avoid dispersion of the infection around. Prone ventilation, this is what you do. Awake proning if possible. Lateral proning, then again positioning. In kids, this becomes slightly complicated because you need a lot of sedation. Their compliance is poor. But if possible, sedate them gently and then do prone positioning. That's going to help you a lot because that exposes the lot more lung area for oxygenation. And these are the PRDS strategies: low tidal volume ventilation to begin with, conservative fluids, liberal pseudoanalgesia, then neuromuscular blockage, steroids, avoid at the risk of increased viral shedding. So in general, these are the guidelines for PRDS, but given the COVID PRDS, this could be reviewed and steroids can be used in desperate situation, obviously in the critical ones. Prone ventilation, of course, it can be done, but again, PRDS says it is a high risk due to more staff and ventilator disconnections and even tube dislodgement. So obviously, PRDS strategies are quite good to go on with. To same situation for COVID PRDS as well. Don't forget to manage the systemic side effects of this ARDS and the whole gamut that comes to you with COVID. They will be in shock, so you have to have restricted prescribed fluid boluses. Don't give too many of fluid because that is going to hamper you more. So you stick to 10 to 20 ml of fluid boluses or if possible balanced salt solution. Adrenaline infusion. Myocarditis, you can use diuretics, anodilators and ECMO. Obviously now ECMO has come up in a big way, but still the benefits of ECMO in pediatric, in COVID, obviously very, very limited. Immunomodulators, IVIG may be considered in bad clinical situations, but as such on its own for severe COVID, IVIG use is very doubtful. Acute kidney injury, so you look after the kidneys well, make sure that you have conservative management where the kidneys can get affected and go into an anuria and renal failure. So you have to give a good trial of diuretics. If not, then you need to sort for the renal replacement therapies like either peritoneal dialysis, hemodialysis, or if you have facilities for CRRT, you can go ahead with CRRT. Obviously, liver can take a hit as well. Coagulopathy, you can get lots of coagulopathy, DIC, so keep a eye on that. Keep managing the coagulation and give blood components conservatively. Obviously, this can affect your respiration as well. So be very, very conservative on that, only if needed. And when you have this situation with cytopenic release syndrome, you can use medications again. Saying so, this is documented with tocilizumab, now remdesivir, but these medications are not proven for use in pediatric population. This needs to be used with lot of caution, lot of advice from infectious disease people. Worldwide in pediatric, use of tocilizumab is slightly better as compared to remdesivir, but again, side effects are too. Pharmacotherapy in specific severe COVID, enoxaparin, which is your Clexane, is something which is very helpful, and you can use that. But make sure that the platelet counts is adequate. If you have platelet counts which is dropping less than 80 to 20,000, you cannot really use them very straightforward. Similarly, if you have very fluctuating INR abnormal or there's hypertension, you wouldn't be using. But the dosage, as I said, this can be used. These dosage are from around 0.5 milligram per kg up to 1 to 1.5 milligram per kg. So prophylactic as well as therapeutic dosage. Steroids, either dexamethasone or methylprednisolone. Dexa has come up in a big way now. So 0.2 to 0.4 milligram per kg. Only for 5 to 7 days can be extended further. Methylprednisolone also can be used depending upon what part or what type of severity that you're seeing. If you're seeing the immunological response or abnormal MIS-C patients, then you may use these. We'll talk about them in detail later on. Remdesivir, again, unproven role and efficacy in pediatric population. It's an antiviral, but if you're told you have to, these are the doses that they have advised. Between 3.5 to 40 kg, you can give a loading dose of 5 milligram per kg, followed by 2.5 milligram per kg once daily for 5 days. Similarly, for kids who are more than 40 kg, 200 milligram IV on day 1, followed by 100 milligram for every day for next 4 days, followed by tocilizumab. It's an immunosuppressor, leads to a lot of underlying, underlying chest infections, kidney infections, renal failures, fungal infections. So you need to be really careful with this, using this, unless you have an ID person like the infectious disease consultant. You have to take his opinion whether this is useful or not. We haven't used for any of our patients so far. Neither we have used remdesivir. IVIG is I think is reasonably good to use. So effectively, if you take out these two, remdesivir and tocilizumab, we are left with steroids, IVIG, and low molecular weight heparin, and of course the respiratory support with oxygen. Nothing much really on pharmacotherapy for pediatric population. And remember, this is what it is. All across the world, people have done things, but nobody has found, even in adults. Forget about pediatric. And how do you decide about discharging these patients? I think this is a slightly older discharge policy, which has come from ICMR and the Ministry of Health and Family Welfare, Government of India. So milder patients are discharged after 10 days of symptom onset and no fever. This was in the days when they were all advised to be admitted. But obviously you can now send them on home quarantine, patients who don't have symptoms. The moderate ones which have fever resolved within 3 days and oxygen saturation maintained without support, we can discharge them. I think we can straightforward discharge them here. Similarly, symptom not resolved and they want oxygen therapy as continues only when they are off oxygen and maintain their saturations for 2 to 3 days, consecutive days, you can send them home. Severe, of course, they must be completely clinically recovered from all the illness that they had. And then they have tested negative, and this is actually the old one. So nowadays we don't do repeat RT-PCR. Clinically, when they stop, any requirement of support such as oxygen or inotropes or fluids, and they are good to go for 3 days without any fever on their own, they can be discharged. So this is what normally you would do. No RT-PCR required before discharge now. So what I would want you to remember with the severe COVID is COVID in children can be severe, really severe. It can be, but luckily it is not very common. It is rare. We don't see very bad pediatric patients who require ventilation so far as I know, even on the intensive care circuit. Most of the children are asymptomatic, but they can spread the disease in the families and, of course, the pediatricians. As Sir had said before, we need to be careful and protect ourselves from these patients. There are no specific medications, as you see, as we spoke about. So oxygen, steroid, anticoagulant, and of course, you can add IVIG to that. It remains the best bet at the moment. And importantly, any child who you think is worsening with suspected COVID or positive COVID and may be needing oxygen, he or she has chances of worsening. So make sure that this child reaches the nearest PICU at the earliest, so that the support can be given and they can come out with this minimal support as well. What remains important is the face shield, mask, and hand hygiene, as the importance cannot be more emphasized. And we had a good lecture with that as well. So I hope we made ourselves into this situation. And this is what nowadays people are putting up. And this is really not good. So I've seen somebody putting this mask on the car as a, which is really a horrible thing to do. But remember. Thank you very much.
Yeah. Thank you, sir. Hello.
Hello, yes, go on.
Yeah. Thank you, sir, for this wonderful and lucid, very informative talk. You have covered almost all aspects of this management of and spectrum of severe COVID disease. There are a few questions for you, sir. Like you have said about the role of definite role of steroids.
Yes.
You have said about the stages of COVID. Initially, it will be a viremic phase, and later it will be like an inflammatory phase. So, like at what juncture we should start the steroids? When the child arrives, or if they start developing breathlessness, or you want to wait for 7 days from the onset of symptoms? Like
it's a very tricky question with regards to the timing of the steroids. What I normally tend to do is any child who you would see and you think that this child is getting breathless and he starts dropping his saturations, and then you need to give him oxygen. That's the time you should start thinking about starting him on steroids. But you know, you can give him some time with oxygen. They may settle down with oxygen. But if the child continues to require oxygen beyond 24 hours and is not settling down, you can start them on steroid. Because we had few patients who required only oxygen, and then probably within 2 days, 48 hours, they recovered, they came off oxygen. What they needed was only oxygen. So I wouldn't jump straight away to start on steroids, but if there is definitive oxygen requirement beyond 24 to 48 hours and child has persistent tachypnea and breathlessness, you can add on to steroids.
Okay, sir. Fine. Then, sir, like in your case, what you have very excellently managed that 7-month-old girl. In that case, you have used Thymine to just get rid of the fluid. So, what exactly does it works?
Basically, Thymine was used in the because it has a role in oxygen consumption. The way the SpO2, the way the SpO2 increases, it is the amount of oxygen that is utilized in the body is reduced. So Thymine can be used on that front. The adult critical care has actually documented now. The new guidelines have also mentioned about Thymine use. I mean, if you ask the older pediatrician and really the old time, they used to use for wet very. The Thymine is one of the vitamin B complexes. So that can be used and it can be given for 5 days.
Hello. In the same case, we have started on anticoagulation, sir. And we have changed the anticoagulation to aspirin because of the persistence of fever. So I just wanted to know that how long this anticoagulation should be continued, and in which cases should we continue aspirin?
Most of the time, if you look at our case particularly, our case had a strong thrombocytosis. Actually, from the day one, our platelet counts were around 9 lakh. And we tried to look into it, that whether this is looking like a Kawasaki, whether this is looking like a Biggs, this is looking like a Missy, but all her parameters, all the parameters were, absolutely normal, except that high platelet count, and it remained high. So when we started on anticoagulant on day 3, day 4, because her oxygen requirement worsened, she was started on steroids. although her D dimers were not really high as such. So D dimers on its own and alone cannot be just the sole criteria of starting on anticoagulant. But if the child has a combination of high oxygen requirement, breathlessness, and then there is a worsening lung parameters, and then there is a X-ray and the CT evidence, and a child is actually slipping into a from mild to moderate to severe part, then you can always initiate the anticoagulation. You can continue to give it for 7 days at least to start with. And if you think that in our case, why we persisted with aspirin was she started developing a significant amount of fever. She had persistent thrombocytosis. Platelet counts never came down beyond 5 lakh till the time of discharge. And that was one of the indications for starting on aspirin. So she went home on aspirin.
Yeah. For Kawasaki, yeah, okay. Then, sir, as far as the intensive care management of this severe COVID ARDS is concerned, we have good compliance and poor compliance lungs. So, how to clinically differentiate these two? Like, are there any clinical indicators or by investigation? Like, you have said that low tidal volume and high tidal volume strategies. So
yeah, I think that there are two ways of looking at it. The low compliant and high compliant lungs as per the adults, but this is not really very applicable to pediatric patients as such. So what you would go with is your oxygenation and PO2 FiO2. So if your PF ratio is reasonably good, then you have a compliant lung. So if your PF ratio is dropping down, then you have a non-compliant lung as well, and you are requiring higher pressures. So in that situations, obviously you are dealing with a non-compliant lung, and that would be a different way. So you can accept, sort of permissive hypercapnia, you can accept slightly, lower pH, you can accept slightly low oxygenation, and go on ventilating them with low tidal volume but high P. So that can be your, sort of lungs which are which can be as non-compliant as well as compliant. Compliant one can go with a higher tidal volume.
Okay. Is there any benefit of doing HRCT to differentiate between these two?
It can be helpful. I mean, HRCT, if it is available, it is definitely good. I mean, you should do HRCT once the child is worsening and has, is requiring more and more oxygen support. It is not going to change your treatment as such, but it will help you document the level of involvement. Basically, that is more of a understanding of the severity of the illness rather than as a part of the treatment, because obviously you will go ahead with the clinical acumen with your oxygenation and the lung compliance rather than the HRCT.
Yeah. One more question in the chat box is what sedation do you prefer? It's as like a routine sedation or routine specific? Yes. It is like a routine sedation.
Fine. And if at all you can give oral sedation, that's also fine.
Okay.
So any of dexmedetomidine also can be used in general.
Okay. Yeah. Thank you very much, sir. Yeah, cleared all our points.
Venkatesh, one question just I wanted to ask, sir. Suman Patil, sir. We said we are not at all using almost tocilizumab in pediatric population because fortunately we don't get that much severity what we get in adult patients. But the notable thing is that in government setups we have available pediatric preparations, 80 mg per ml or 200 ml. So what would be the ideal scenario when we will be using that? In what situation? Just hypothetical thing, but just because still we are in early phase, we don't know what we are going to face later on. Suppose
use of tocilizumab even in adult critical care has been looked at with a lot of suspicion whether it helps, whether it doesn't help. If you ask me, in Dinanath, even the adult intensivists now, they do not go for tocilizumab at all. I mean, hardly anybody now. Our usage has dropped down significantly after the initial, what I should say, the excitement around tocilizumab. Everybody were quite speculative, but it was good that we never went ahead with tocilizumab, bang, we never used it. And obviously, it is fraught with a lot of problems. As I said to you, there is a lot of underlying infection, secondary infection, liver dysfunction, kidney problems, and adult patients had been diabetic, have compromised liver and renal. For pediatric, there are no, I would say there are no as such papers coming out with utility of tocilizumab in pediatric population. But whatever the papers are available from US and Europe about tocilizumab were used in PIMS or the MESC patients, and that too in a desperate situation. Again, they are not the first liners for any of these, neither in a severe COVID in pediatrics, neither in MIS or PIMS. So even in MIS or PIMS, they are probably third or fourth on the line. So first and second is always the IVIG followed by steroids and aspirin. And then fourth, you can think about possibly tocilizumab. So I would stay away from tocilizumab definitely.
Yeah. Thank you very much. Good.
Thank you.
Yeah. Thank you, sir.
Thank you.
Thank you, Venkatesh sir. Thank you, Sumant sir.